because of a simultaneous contraction of agonist and antagonist, and they just keep contracting. And on top of that, there's painful muscle spasms. Hello everyone, happy Friday. Welcome back to another episode of the Brain PT. My name is Lily, I'm a neurologic physical therapist, and I'm so excited that you're here today because it's a really interesting diagnosis that we're going to talk about today. Today we're going to be talking about stiff person syndrome or stiff man syndrome, and this is such an interesting diagnosis. And if you already knew or know, Celine Dion, who is an amazing singer, I used to sing her songs when I was a kid, she was recently diagnosed with SPS, stiff person syndrome. So that has brought some sort of awareness to this disorder. So now let me just tell you that I have not worked with someone with stiff person syndrome. I've just seen a therapist who worked with that person, but I have never had the experience or ever met someone with stiff person syndrome. So let's get started. So stiff person syndrome is a rare, progressive, and often underdiagnosed immune-mediated disorder of the central nervous system, presenting with progressive rigidity and triggered painful muscle spasms in the axial, or predominantly in the axial and proximal limb muscles. It was first described back in 1956 after a series of patients, 14 patients that would complain of rigidity and fluctuating tightness. And this tightness was triggered by emotional stress and other triggers. Now, when I say emotional stress, it is important for you to know that this specific diagnosis, due to the emotional triggers, SPS, stiff person syndrome, is often misdiagnosed for a functional neurologic disorder or any other psych disorder. So there are different classifications of SPS. One is the classic SPS. Two, it's the stiff limb syndrome, so a problem with just a limb. And the other is called PERM, P-E-R-M, progressive encephalomyelitis with rigidity and myoclonus. So progressive encephalomyelitis with rigidity and myoclonus. So this PERM, it's known as SPS plus syndrome, and these patients have rigidity in the axial and limb muscles. They have diffuse myoclonus, and they have prominent autonomic instability. Now, how do they diagnose this disorder? And then we're going to talk about the presentation. So they discovered this specific antibodies, and there are several antibodies, but this is the most prominent found. It's called the anti-GAD, so glutamic acid decarboxylase, GAD. They discovered this antibody in people with SPS, and they found it in their CSF, cerebrospinal fluid. And this antibody was present in other people with autoimmune disorder. So, that made him think that this disorder is an autoimmune disorder. And interestingly, SPS might be more common in people with any other autoimmune disease. The other thing that they do is EMGs, nerve conduction studies. So with the EMG, and they assess the motor units. So their motor units are continuously activated. So there's continuous motor unit activity giving rise to that rigidity, and that activation continues despite relaxation. This motor unit activation is more prominent in axial muscles, so thoracolumbar paraspinal muscles, and rectus abdominis muscles, but can be found in proximal, upper extremity, and lower extremity muscles. So proximal and trunk. The peripheral nerve conduction studies are often normal, and the rigidity and the continuous motor unit activation can be less or even disappear if the patient is in a like sleepy state, like a calm sleepy state, or under spinal or general anesthesia, which confirm that this disorder is centrally mediated. So there's a central source. Now let's talk about the symptoms for this disorder. So we're going to classify, as rehab therapists, we're going to classify in different things. So one, we're going to talk about the rigidity. We're going to talk about the spasms. We're going to talk about their gait, and we're going to talk about the triggers. So these patients present with muscle stiffness in the trunk and in the proximal limbs because of a simultaneous contraction of agonist and antagonist, and they just keep contracting. And on top of that, there's painful muscle spasms. Now that rigidity, it's usually in the thoracolumbar region. So, and it's symmetrical. Okay, so this rigidity, this stiffness is symmetrical. And because there's involvement of the lumbar paraspinal muscles, they start presenting with an exaggerated lumbar lordosis. And then they start losing, or they present with limited range of their spinal range of motion or truncal mobility, especially reduced spinal flexion. The rigidity fluctuates in severity from a mild rigidity to a very severe stiffness that patients describe as like walking like a tin man or walking like a wooden man, because it's just so severe. Now eventually this is why we need to consider and turn on those orthopedic brains if you're a neurotherapist. This eventually will lead to orthopedic abnormalities, such as that increased lumbar lordosis causing low back pain, joint deformities, abnormal posturing, which might result in like a statue appearance, which if you think about it, during gait, they might just walk without that natural trunk rotation. So that's something to consider. We need to turn on our orthopedic brain. Okay, let's talk about the spasms. The spasms are typically painful, and they begin as a myoclonic jerk that is followed by a tonic activity. So if you think about like tonic-clonic seizures, tonic-clonic is tonic, you're gonna see the patient contracting, going into this rigid contraction, and then clonic is when you see the shaky, right? Or that's not the best term, but when you see the clonus contraction. So it's the same thing. So with the spasms here, you will see the myoclonus jerk followed by a tonic activity. If they try to move a limb during that spasm, it might be difficult because of that simultaneous activation of agonist-antagonist pair, and therefore they just cannot move as they want. Those spasms can even cause fractures at times, and some articles say that the strength of those contractions might even move pins if they've had any type of orthopedic surgery. So now we're going to talk about the triggers. What can trigger these stiffness and these spasms? Things that are present in everyday experiences can be a trigger, such as noises, or a sudden noise, sudden touch, sudden movements, even emotions that they might experience like anger, nerves, anxiety. All of those can increase muscle stiffness and spasms. Even cold weather, an infection, or even just, like I said, cutaneous stimulus can trigger this. Patients often develop depression, and they develop task-specific phobias that are related to things that bring on their stiffness and their spasms. So you can only imagine how everything can turn into being debilitating if they bring on that spasm and rigidity. They also present with pathological startling response, so they might get startled quickly, and that may be a trigger. Now, phobias, talking about phobias again, are very frequent in people with SPS, and these phobias can be even things like walking among crowds, and this is reported on the research that people actually say they have a phobia to this. Walking among crowds, such as airport, malls, walking outside, crossing a street, going up or down the stairs, going up or down the elevator. So things like that are a phobia and therefore a trigger. So these task-specific phobias are associated with anxiety and emotional upset, especially bringing on fear of initiating or completing a task. So let's take walking as an example, and here we'll bring in gait. So let's say they have fear in initiating or completing a walking task. This might result in trouble with follow through or initiation of gait, and therefore causing like some sort of freezing and then causing a fall. So you can see how this might be a cycle of kind of like fear avoidance, and we as therapists need to play a role in bringing on some sort of success to break the cycle. Now, clonic jerks, or those myoclonic jerks of the legs and the trunk, might cause a unexplained fall without loss of consciousness. So this can be confused with a drop attack. So just keep in mind that it might not be a drop attack. It's basically the myoclonic jerk. Now, the last thing I want to talk about is that people with SPS might present with autonomic dysfunction. Many patients exhibit autonomic signs such as diaphoresis, pupil dilation, tachycardia, tachypnea, hypertension, and hyperthermia. Repeated spasms that are pretty close together might resemble tetanus, and these people might also present with severe autonomic involvement that they might need intensive medical care. These people also present with exaggerated startle responses to acoustic and tactile stimulus. Now, the last thing is that this condition eventually stabilizes and may remain static for several years or even decades. On part 2, because this was going to be an extremely long video, on part 2 we'll discuss what to do from a PT standpoint or a rehab standpoint, and it'll be kind of just shedding the light on how to start. From my own perspective, it won't be supported by research, but since it's lacking. The research in stiff person syndrome physical therapy is lacking. So here I'm going to share with you some things that I think I would start doing if I would have a patient with SPS. So I really hope you enjoyed this video, and I will see you next time.